Welcome to BioBalance Healthcast. I'm Dr. Kathy Maupin.
And I'm Brett Newcomb. And today we're going to continue a conversation that we began about replacement of testosterone improving libido, but not as much for everyone. That some people receive better benefit than others, better results than others, and there are complicating factors. I mean, it's not always going to be optimal for everyone. And we talked about that extensively, but afterwards we were having a conversation, we realized that we hadn't made a distinction in the conversation that we wanted to make. We want to divide a conversation about sex and satisfying participation in sex or capacity for sex into two segments. The first segment being the arousal segment. Do you desire sex? Are you responsive? Does your body prepare itself to participate in sex? And the second section be the payoff or the closure of the sexual act that we call orgasm. And so we want to talk specifically about some elements relative to orgasm, and we want to talk specifically about some elements that are relative to the arousal state. For example, one of the points that I made in the last podcast was that people who are on antidepressants often lose that libido desire, but they don't lose the capacity. They just don't innately feel horny. They don't feel aroused themselves, like, oh my gosh, I forgot to have sex. Doesn't occur to them.
I didn't know that occurred either, but that's
well,
okay.
It does. So when I work with couples that have those issues and are on those medicines, I really make the point to them, you need to know this information, you need to be talking to each other about this information, because it may become your responsibility for a while to be the initiator.
The one that's not on the medication.
The one that's not on the medication. And it's not because the other person finds you to be unattractive, doesn't want you, doesn't love you, doesn't desire you. It's because their body isn't working. And if you know that, you can compensate for it. What I didn't say, that I wanted to go on and say, is that whether that's a factor in the relationship or whether the other partner agrees to compensate and become the consistent initiator, frequently what happens with these couples as well is if you're the party that's on the antidepressant, when you reach the point that you are ready for an orgasm to close out the deal, what sometimes happens is like somebody reaches over and unplugs your television just as your show's about to start. Everything just stops. It's not there. It's as if you weren't doing anything, and it's at the most inopportune moment. And they don't know to expect that. They don't know how to understand that. They think, oh my God, something is really wrong. They often think, it's wrong in my body, am I going to die? But sometimes they think in terms of the relationship. He doesn't really love me, she doesn't really want me.
And all it has to do is chemicals. It has to do with chemicals in your brain, that the serotonin is blocking dopamine to neurochemicals, neurohormones, and the dopamine can't close the deal.
Can't close the deal.
So it blocks those two. It actually stimulates serotonin and blocks dopamine, but serotonin is a definite brake on the car. It shuts everything down, and dopamine's supposed to push you toward orgasm, but if it's blunted by the medications you're on, you just can't get there. Testosterone does help some of those people, but not all of them. It can't overcome that in some people.
If it's blunted by the medications, or if it's blunted by the habits of your lifetime. For instance, if you're addicted to alcohol abuse.
Right. Alcohol and narcotic abuse can cause you not to have the same effect from testosterone, not to have the same effect in your brain for both desire and orgasm, because your brain is insensitive to the neurotransmitters that are there. So it's not like you're not making the right neurotransmitters. It's like it needs a lot more of them to get the same effect as what a normal person would have without that kind of addiction. So it's changed your neurochemistry.
It's reset your base. What would be the baseline for 90% of the population, say this is the point at which they would feel desire or have orgasm. For somebody that has those addictive issues, their base for being able to trigger that event is going to be significantly higher.
That's right. And a lot of people who have had alcoholism and are dry take antidepressants, which makes it even harder.
Which compounds
it
the problem.
compounds it. So as you add up all of these things, it's an illness to have alcoholism or an addiction. So those illnesses, even if you're no longer taking alcohol or narcotics, it has changed your brain. And your brain is going to have more stimulation. And then the antidepressants counteract that. So as you add these things together, it makes it harder and harder for just hormones to stimulate and activity of sex or desire from your partner to actually work. So we have to one by one get through these, either with counseling or with changing medications or with increasing testosterone levels to a much higher level to overcome the neurotransmitter barrier, that you can't get to that. You have to get above what normal people get to actually feel the same.
So does that ever create conflict between you and other physicians? Because you're not the primary care physician. If I come to you and you give me testosterone and I have an alcohol abuse history and you give me enough that it's going to overcome that barrier, and then I go back to my regular physician and they do a blood test and go, oh my God, you've got...
It does. It does, and oftentimes I have to write letters or transmit the
rationale
through the patient. I usually have to anticipate that and say, now, your doctor's going to say, oh, you shouldn't have this much testosterone.
Right.
It's the testosterone of a 19-year-old. Well, true, you should have the testosterone of a 20 to 30-year-old. However, I have to push it in people who have these barriers or this history.
Right.
And it doesn't look like that to your body. It's not doing any harm.
Because that's a measure of total testosterone,
right,
not free testosterone.
Yeah, and the free testosterone, most doctors don't even know what you're supposed to have. You should have men should have a free testosterone above 129, and women should have a free testosterone over 10, and usually over 20 to really get everything back if they're over 40 years old.
So most of the testosterone that's in your bloodstream binds with a protein and it circulates in your blood. It's inert or inactive. It doesn't do anything.
It's invisible to your body.
And then that portion of the testosterone that does not bind with the protein is the free testosterone.
Right.
And that's the golden piece. That's the part
I have to get high enough to have people who are on nothing get back to the level they were or a little bit higher than they were when they were in their 20s to 30s. That's the range where you feel normal. And in people who have other issues, I have to push it past that. The free testosterone is the key. And that is really what I'm looking at. I don't really care what the total is. The total's not going to harm you because it's not doing anything.
So Kathy, when you're working through all this sort of chemistry set, lab set analysis, and you're talking about hypertension, you're talking about liver disorders, you're talking about alcoholism histories, you're talking about antipsychotic medicines, all these things that you're trying to regulate. Are you working on both ends of the spectrum, the arousal, libido end and the orgasm end, or do they sort of sift themselves out to one or the other?
Well, in general, if you can help the arousal end, the orgasm end gets better.
Takes care of itself.
Right. And so in general, it's the same factors. It may be a different level in some people.
Okay.
And you take care of all the psychological issues. Many people can have libido, but don't feel comfortable enough to have an orgasm.
Right.
Or they've been abused, or you're going to talk about that. But many of those issues don't affect libido, but do affect orgasm. And
yeah, I had a client that, just to digress into that for a moment, a couple that came to see me that were happily sexually functioning. That wasn't the issue in their relationship, but as a side effect of our conversations, what they told me was that they had discovered, or she had discovered, she could not have an orgasm unless she used a vibrator to stimulate her clitoris. And she could do that while she was having sex with him, but she couldn't ever just have an orgasm through penetration sex with him. So we started talking some about the fact that there are trigger sites for women. There are 3 different trigger sites where women can achieve enough stimulation to release an orgasm.
And there's 3 different orgasms. They usually feel different to a woman if she's had more than one type. But it's clitoris is the most obvious. It's on the outside. It's easier to get to, and usually it has. It's the first thing women find to actually masturbate so that they can have an orgasm on their own. So the clitoris is what everybody thinks of as what you stimulate to achieve an orgasm. But the other 2 sites are the G-spot, and yes, there is a G-spot, and it's on the top part of the vagina, right about 1.5 inches from the outside, and it's what they think would have been a prostate if we were men. And it's a little area of nerves, a bundle of nerves, and it feels like a little bump. And it actually is a place you can stimulate
And it doesn't move
orgasm.
around. It's
No,
a discrete location that you can
It's
find.
discreetly right there, and you can feel it. Most women have to find it on themselves before they teach their partner where it is.
Mm-hmm.
And then the third kind of orgasm is the cervical orgasm, and that's from penetration and from pushing on the cervix by the penis. So
The
it has to
massaging
be,
of that spot.
right, or just pressure on that spot.
Okay, so you were telling me when we were discussing this, I mean, as a gynecologist, she knows all this stuff.
Yeah,
As a
I
man,
know.
I'm clueless. But you were telling me that there are nerve bundles that go from each of those trigger sites to the spinal cord to send the message of stimulation and amount and tolerance and all of that to the spinal cord, so the message gets to the brain.
Right,
that
because
says,
the orgasm's really in your brain, but the stimulation is elsewhere.
right. And so there are 3 different bundles of nerves that go to 3 different locations in the spine. So there truly are different orgasms.
God kind of built us
Uh-huh.
so that there were fallback systems in many of our systems of our body. And
NASA calls that a redundancy system.
yes, I know, and we're glad we have three orgasms, by the way. But we're glad that if there's an injury or if there's something that happens to the spinal cord or to the area where you would normally be have the trigger point, then there are other areas that can do the same thing. But because of the redundancy, it doesn't like all come together to one nerve and then go to the brain.
Right.
It does eventually, but it goes to different parts of the spinal cord, so they're in different areas. So if you were to have paraplegia, one of the sites would still be workable. It's in your thoracic spine, so it's higher than most people have paraplegia, which is usually at the very bottom of the thoracic spine. So this actually is kind of a fallback
one?
system.
Which of
The clitoral stimulation goes to the thoracic system.
So that for paraplegics, that still then could
That's
be a functioning.
still functioning.
Okay.
So in these ways, we have, our basic reason for being here is to have babies. Not our modern reason, but our basic anthropologic reason is
Right.
to have babies and to fill the earth with people. So basically, that's that's not religious, that's just anthropologic knowledge. And so we have to have multiple systems that keep us having the payoff for having sex, because it's not fun to have babies, obviously. So you have to have a payoff to get there. And the payoff is orgasm and the pleasure of having sex. So these different areas are maintained even if there's injuries, even if there's something that happens.
There are injuries.
stops
You somebody's paraplegic and loses access to those other 2 nerve bundles. There are cultures in the world where the dominant males practice what's called excision.
Right, that's
which-
mutilation. That's another word for mutilation
but
of
they,
the clitoris.
they remove the clitoris of their daughters.
Right.
To hopefully, not make them enjoy sex enough that they want to go out and be unfaithful.
That's the goal. That's their goal.
That's their goal. But what they don't know in those cultures, there are 2 other areas
Don't
where...
tell them, okay? Because
I
I don't
won't.
want them doing anything else to their
I
daughters.
doubt if they're watching our podcast.
We
but-
just don't want them
But
to
as a
know this.
gynecologist, you, through the years, have performed a lot of necessary hysterectomies.
Right.
And there is a controversy among gynecologists about hysterectomies in terms of, do you leave the cervix in or do you take it out as part of a hysterectomy? And you recommend what?
I recommend leaving the cervix in unless there's cervical cancer, because the cervix has all of the nerves for that third orgasm or that other orgasm in it. And if a woman's orgasms all came from penetration and pressure on the cervix, and I take her cervix out, she's lost her usual orgasm, and she will be very unhappy. And that is not my goal. My goal is to leave someone intact and just take out the part of the organ that's the issue, which is the uterus. It's bleeding or it has fibroids. It doesn't do a thing to your hormones. When you remove the uterus itself, and it doesn't do anything to your sex life if we leave your cervix. So having a cervix and ovaries maintains your sex life. We can just get rid of the offending part of the uterus when we're done having children. So the hysterectomy just means removing the uterus. I remove the part above the cervix. When I was doing surgery, I no longer do surgery, but I did that for a very long time. And the other surgeons in the operating room would come in and make fun of me because I was doing it
You're
this
taking more
way.
time and being more careful to do that.
Yeah, it didn't even take more time. They made fun of me because of why I was doing it. Because I was doing it to maintain orgasms, and they'd say, "Hey, tell us about orgasms, and tell us about why you leave the cervix in." I mean, it was a joke, but it wasn't a joke to my patients, and it wasn't a joke to me.
And especially not.
And that's why it's so sad that medicine finds that to be an issue. We should be maintaining people's sex lives. That's part of their health.
And part of where we've gone in this conversation is we've looked at the capacity for damage to any of the three sites that might remove that site as a trigger point for orgasm. So let's reverse the conversation for a minute and say it's a healthy woman who has all three trigger sites in place. You say she can have 3 different orgasms. Can she have those at the same time?
Yes. You can have them at the same time, but it's a trick. It's a trick to stimulate all 3 areas at the same time.
A skill.
It's a
skill.
skill.
It's not a trick. It's
not
a skill.
one that I'm teaching.
It is amazing.
I don't even know how I would teach that, but they've told me they have it. I haven't asked the particulars.
Yeah. But so I asked this question off camera, and I'll ask it again because I know it's going to occur to the men that watch the show. Is that event happening that way what we mean when we say somebody is multi-orgasmic?
No.
Okay.
Multiple orgasms generally mean successive orgasms,
Yes.
and it doesn't matter which site they come from. They're just successive orgasms.
But most women have a preferred site, and preferred in the sense that that's where it generally happens for them.
Right. Right, and then they have to be much more adventurous to even find the other sites, or their partner does, because those sites aren't, I mean, the obvious one gets you where you want to go.
Right.
But you have to be more adventurous to find the other sites if you already have orgasms to see if they work. And then it takes some time in figuring out, is this going to work for my partner? You know, the guys come in and I don't know how to do that. Well, this is what you have to do. I'm not sure how you're getting there, but you have to move the cervix, or you have to find the G-spot. And those are things you have to do as a couple.
And which comes back into my domain in terms of encouraging people, helping people learn to be safe and more comfortable talking to each other about what works and what doesn't work,
And that's the
about what
hardest
they
thing.
need, what they want, what they fantasize about. And couples are so reluctant to do that. There are all kinds of cultural taboos about doing it until you get married and it becomes okay. And many couples find a lot of resistance to that kind of conversation and those kinds of exploration.
That's
and
right.
If they can get past that, they really develop a lot of insurance against troubled times because of their ability to relate sexually in a more satisfying way.
But we come from different families. We come from families that are very closed, very open, people who close the door when they go to the bathroom, people who open the door when they go to the bathroom. I mean, you come from 2 different total cultures when you marry somebody, and usually you don't marry somebody exactly like yourself. So diversity is part of genetic sharing. You know, we kind of look for somebody who's different. And so when you have somebody who's different, they had different backgrounds. It's hard to make a sex life after that.
I'm thinking of the Farkle family from Laugh In.
I wonder what you were laughing about.
I don't know if you remember that scene, but all the Farkles looked exactly alike, except
Yeah.
and they look like the neighbor, not
Yeah,
the dad.
that's true. But I'm
We're talking about diversity.
we were talking about diversity and how you choose a spouse, and that's generally the case. But when they have to be enough like you so you accept them, but they have to be diverse in other ways, and usually that means different families, different ways of doing things. So you rarely find a couple who both families and both backgrounds are just very open with sex. I mean, that's just kind of different.
Well, there are cultural messages.
It's hard to get past this barrier.
Growing up in the Deep South in the 50s and 60s, there were cultural messages that I received about sex as an adolescent
Besides,
male.
don't do it.
Well, it was sex is evil, mean, bad, and nasty, so save it for the one you love.
Yeah, it's very conflicting, and what we tell our children is very conflicting about sex.
Yeah.
Because we tell them, what we tell them is setting them up to have a terrible sex life the rest of their lives.
What we tell them and what we market them in advertising and movies and media are 2 totally different things. And now they all have media access points that go around whatever we tell them anyway. So they're going to access a whole, but that's a conversation for another day.
That's a different conversation.
So let's wrap this one up. We're talking about arousal and orgasm, and we're talking about, especially about orgasm. I think the point I would like to close on is you were discussing that some women come in who are anorgasmic, who report that they have never ever had an orgasm. And there may be a lot of reasons for that, like sexual trauma histories, but the simplest reason and the most easily repaired reason, according to your experience, is they have not enough testosterone.
That's true.
And if you simply give them enough free testosterone in their body, there accumulates enough that switch will throw when it would never throw before. It's like there was never enough current to turn the light on.
And I see that when they come in and they're like, "Ooh, I didn't even expect this."
Yeah.
But this came. I now know what this is, and now I'm having orgasms every time we have sex, and I'm like, you must not have had enough testosterone your whole life, because it wasn't their goal to get an orgasm even, because they didn't know what they were going for.
They didn't know what they were missing.
But once they got enough testosterone supplied, they had orgasms.
Yeah. And so that is the simplest, easiest, quickest fix, most reliable fix. If that doesn't do
For
it,
that problem.
then there may be other complications that you have to look at.
And we always have to look at everything in someone's background to
Sure.
find out why. And sometimes it is psychological, and sometimes it does
Yes.
have to do with your past. Maybe even if you've buried it and you have to dig it up, and it's not
Right.
fun doing that.
Right.
But it takes a long time of counseling and having to go through that. Many people come out the other side being very, very sexually normal. After they've gone through the counseling, they can live now as a normal human being. But what I deal with is really figuring who needs you and who needs medical care and who needs an adjustment.
Well, we do the
or
same thing on our
addition
side of the coin. I
testosterone.
mean, ideally, you have relationships with physicians that you can send your patients to that you trust and know, and say, will you look at all of the physical, physiological components of this, and then work with me as I work with them on the psychological, emotional components. You know,
And
so it's a team approach.
We work. Yeah, we have to work as a team. And one of the last things I wanted to mention was that all of the young women who take birth control pills are decreasing their testosterone, because it's oral estrogen, and oral estrogen decreases their level of testosterone total and free. And so they're suppressing their ovaries from ovulating, which is great because they're not getting pregnant, but they're decreasing their sex drive as well.
Which means they won't have sex as much, which also decreases the chance they'll get pregnant.
Right, so that may be how birth control pills work. I'm just joking, but they work by stopping ovulation, but they
Right.
also work by decreasing sex drive, which is, not good when
I've
you're
never
married.
heard that before.
Well, it's
That's
very
a
common
negative side effect
of a
that,
birth control pill.
that I would expect I would have heard, because I talked to
thought
a
you
lot
would
of
have
people
heard it
about
too.
those
They
things.
don't know
Yeah.
that, though. They don't know to tell you that.
Yeah,
You have to look for it.
yeah.
And when some young women, when you take them off birth control pills and put a Mirena in, they get their sex drive back.
Wow. All right, so if people have questions or comments that they'd like to make about this conversation or others,
They can send us a note at podcast@biobalancehealth.com, or they can go to our website at biobalancehealth.com, or call my office at 314-993-0963.
and they can always reach me at brettnewcomb.com.